Good morning or good afternoon, everyone. I'm Dr. Narag. I'm a third-year resident here at the DOH Eye Center. We would like to welcome you to our online learning course for the general practitioner in ophthalmology. For these slides, I would like to thank Dr. Pia Galvante, who contributed her slides for your online lecture. For general practitioners, ophthalmology may seem like a foreign world, with daunting terms, skills, and procedures that confuse us. However, the general principles we apply in managing our patients holds true also for ophthalmology. We first take concise, good history and physical examination before we arrive to a diagnosis, and we institute proper management to our patients. When in doubt, we are always available to be consulted for any concerns you may have. The first part will discuss on the basic eye examination. The 6-point eye examination is outlined as follows, which we will tackle one by one. Visual acuity testing is the vital sign of ophthalmologists. Before we do any interventions to our patients, we check for the patient's visual acuity using various charts before we do any eye manipulation. The principle of reporting visual acuity is as follows. The numerator denotes the test distance of the patient from the chart, while the denominator represents the distance at which a patient with 20/20 vision can see a given line. If the patient is literate, the patient is able to read the Snellen or the ETDRS visual acuity chart, represented by the letter E to your right. The patient is positioned 20 feet from the chart at eye level prior to beginning the test. We then occlude one eye of the patient prior to having him or her read the chart. Traditionally, the right eye is tested first before the left eye. However, if a patient has a pathologic eye, the pathologic eye is tested first in order to prevent memorization of the chart by the patient. The non-occluded eye is tested as follows. The patient is asked to read from top to bottom of the chart up to the letters that he or she cannot read anymore. In this case, the patient is able to read the first, second, and only one letter of the third line. The vision of this patient is thus reported as 20/160 plus 1. In reporting visual acuity, we take note of the 50% rule. That is, given a certain line, if a patient can read less than 50% of the line, you take the line above and add the number of letters that the patient can add on the line that he or she has less than 50% of. On the other hand, if the patient can read more than 50% of a given line, you take the denominator value of that line and subtract the number of letters that the patient is unable to read. In this example, the patient is able to read from the first to 4 lines completely, but is unable to read 2 letters of the 5th line. Therefore, the visual acuity of this patient is reported as 20/80 minus 2. In some instances, the patient is unable to read the largest letter or the first line. In these cases, we ask the patient to come closer to the chart in increments of 5 feet. When the patient is able to read the letter, we then record the visual acuity as the actual test distance. So for example, if the patient sees the letter E at 15 feet, we record the new numerator as 15 over the denominator of the first letter, which is 200. Therefore, the visual acuity of the patient is tested as 15/200. However, for example, if we have the patient move at about 10 feet and the patient is able to read the second line, we ask the patient to move further back until he or she can only see the largest letter or the first line, and then record the visual acuity as such. If the patient is unable to read the chart at 5 feet distance, we extend our fingers in increments of 1, 2, or 5 and ask the patient to identify the number of extended fingers. We do this up to about 6 inches from the patient's eye. If the patient is still unable to do counting fingers at 6 inches, we then proceed to do hand movement and light projection. We move our hands vertically or horizontally in front of the patient's eye and ask if they see any movement in front of the eye, taking care not to blow any gust of wind that may clue the patient regarding our movement. This is paired with light projection, in which we shine a light on the patient's superior, inferior, nasal, and temporal quadrants, and report it as good if the patient is able to identify light direction coming from 4 quadrants, fair if it comes from 2 to 3 quadrants, and poor if it comes from 1 quadrant. If the patient is unable to do hand movement and projection of light, we then go to light perception, in which we shine a light directly onto the patient's eye and ask if they see any light. If the patient is unable to see light, we then record the patient's vision as no light perception. Once we are done with uncorrected visual acuity, we test the patient's pinhole acuity. The pinhole reduces diffraction of light or light scatter and focuses light better on the patient's retina, which improves vision. Improvement of 2 to 3 lines with pinhole acuity compared to uncorrected vision may denote error of refraction in a patient. In infants or preverbal children, we check their vision by shining light directly onto their eye and checking if the patient grimaces or turns their face away from the light stimulus. We record this as having a dazzle reflex. If we are able to show an interesting object to an infant or child, such as a toy, we check if the patient's eye is able to fixate properly on the object, and we record if the patient has a fixation that is centered, is steady, that is, it doesn't move around when it looks at an interesting object, and is able to maintain the fixation for a certain amount of time before moving away to another stimulus. Another component of visual acuity testing is near vision testing. In the clinic, one can test near vision by asking the patient to read the fine print of newspapers or magazines. In order to be more objective, you may use the Jaeger near visual chart, in which there are smaller and smaller letters or numbers that the patient is able to read with a corresponding near vision value. The next step of the 6-part eye examination is gross examination of external eye structures. We examine the patient from out to in, top to bottom. First, we check the patient's eyelashes, eyelids, eyebrows. We check the position of the patient's lids for any signs of eyelid drooping or eyelid retraction. We check the globe for any proptosis or exophthalmos. We then proceed to check the patient's cornea for its clarity. We check the patient's sclera if there is any ectaresia or any hemorrhages present. We check the patient's pupil size and pupillary light reaction. We then check the patient's extraocular muscle movement. The next step of the six-part eye examination is determination of the patient's intraocular pressure. In ophthalmology, we use a device called the Goldmann applanation tonometer. In the clinics or in general practice, one may use digital or palpation tonometry. To perform this, you ask the patient to look down and you use your index fingers to gently palpate the patient's eye. If it is as soft as your lips, it is soft. If it feels of consistency to your nose, it is firm. And if it feels like your forehead, it is hard. The normal digital ocular pressure should be as firm as one's nose. Any harder than this, and one may consider that the patient has increased intraocular pressure, such as those found in glaucoma. If the patient has any signs of open globe injury, do not palpate the eye as it may cause prolapse of intraocular structures. This slide shows what we see through our lens when we use a Goldmann applanation tonometer. You will see two mirrors which we align in a certain way, and we check the dial on the Goldmann applanation tonometer to note the patient's intraocular pressure objectively. The next step in the six-part eye exam is to check for the patient's posterior pole through fundoscopy. We check if the media of the patient is clear or if it has any haziness or any obstructions. We check the patient's optic disc and optic nerve, bearing in mind that a difference of 0.2 in cup to disc ratio may be suspicious for certain diseases such as glaucoma. We check the retinal vessels for any obscurations or any signs of hemorrhages. We lastly check the patient's macula and foveal reflex for any irregularities or abnormalities. The next part of our lecture is on the common OPD complaints and conditions. There are various eye complaints we see in our OPD, but the most common of which is decreased visual acuity. When a patient comes to us with a complaint of decreased visual acuity, it is important to remember the concept of the visual axis. When light hits the eye, it passes through certain structures, a pathology of any of which can cause a decrease in vision. The first structure that light hits is called the tear film. The tear film is normally regular and smooth. However, in environments with dry or windy weather, the tear film evaporates, and this causes vision to fluctuate. The next structure that light hits and passes through is called the cornea, a clear avascular tissue of which any opacity can block light entry. The next structure that is passed by light is called the aqueous humor, a clear fluid in the anterior chamber of the eye, that is, it is anterior to the patient's iris. Sometimes, the aqueous humor may be obstructed by blood or other discharge such as pus, which may occlude vision. The next structure that is passed by light is called the pupil, which acts like a pinhole that directs light better into the retina. Light then passes through the vitreous humor, which, like the aqueous humor, may be obstructed by blood or other material of which light is unable to pass through. Finally, The retina is the structure that is responsible for phototransduction, that is, the conversion of light energy into neurochemical signals that is interpreted by our brain as vision. Pathology to the retina, such as in cases of diabetic retinopathy, can cause retinal detachment that destroys the normally smooth configuration of the retina, hence causing decreased visual acuity and metamorphopsia. Error of refraction is the most common cause of decreased visual acuity in patients seen at our eye center. Distance vision should be checked in all children by age 3, where common errors of refraction such as myopia and hyperopia may need to be corrected to prevent the onset of amblyopia. Near or reading vision is also of particular concern, especially in elderly patients who develop presbyopia. Presented in this slide is a patient with a white opacity on the cornea. This opacity decreases the entry of light into the eye, decreasing visual acuity. Other causes of visual decrease include cataracts, in which the patient's lens becomes opaque, decreasing the entry of light. Retinal diseases can cause decreased visual acuity by destroying tissue such as photoreceptors and the like that play a role in phototransduction of light. Other retinal diseases cause pathology by producing ischemia of part or of the whole retina, hence causing death of the retinal tissue. It is important to rule out systemic diseases when confronted with patients with retinal diseases, as resolution of the systemic disease is important not only to save vision but also to save life. A potentially blinding cause of decreased visual acuity is glaucoma. Hence, it is important to check the patient's cup-to-disc ratio, of which a cup-to-disc ratio of greater than 0.3 to zero point 0.4 may be a sign of glaucomatous optic neuropathy. In children, decreased visual acuity should be treated aggressively, as they may contain potentially life-threatening diseases such as retinoblastoma. On the picture on your left, you see that the patient's left eye has a cat's eye reflex, or medically termed as leukocoria. On your right, you see a child with an enlarged corneal diameter, which may be a sign of congenital glaucoma. The next common complaint we see in our OPD is the presence of eye redness. There are generally 3 common eye diseases that cause eye redness that the general practitioner should take note of. The first red eye differential that the GP must know is acute angle closure glaucoma. Patients like these typically have a history of acute onset eye pain during a nighttime activity or when they are watching the cinema or any condition where they are exposed to a dark environment. Upon closer examination, you will note that the patient has decreased visual acuity as well as a hazy cornea and mid-dilated pupil. On closer examination, you will find a ciliary flush. That is, you will find dilated, deep conjunctival and episcleral vessels arranged radially around the patient's limbus. This is a vision-threatening disease that needs to be managed urgently. The next red eye differential that the GP must know is conjunctivitis. Conjunctivitis may be either non-infectious or infectious. With non-infectious conjunctivitis, the patient typically has a history of being exposed to an allergen. The patient also has a history of atopy. Conjunctivitis that is allergic in nature is bilateral and presents with white, stringy, or watery discharge. This is in contrast to patients with infectious etiologies of conjunctivitis. Infectious conjunctivitis can be either due to a viral or a bacterial cause, and they usually present unilaterally, as compared to non-infectious causes which present bilaterally. With regards to infectious conjunctivitis, they can be differentiated by viral or bacterial etiology by their discharge characteristic. Viral conjunctivitis usually present with watery, non-serous, non-purulent discharge, while bacterial conjunctivitis presents with purulent, creamy, white discharge. This is another slide showing bacterial conjunctivitis in which we note purulent discharge. Bacterial conjunctivitis can be differentiated from acute glaucoma by the presence of matting of the eyelashes. As you can see here, the eyelashes of the patient are bunched up by a fibrinous exudate that is not usually found in glaucoma. This is another slide showing allergic conjunctivitis, which shows clear stringy discharge, and this would present bilaterally in a patient with atopy. Patients who complain of eye redness, especially if bilateral, should undergo proper review of systems, as patients like these may have systemic diseases. Patients with red eye can have collagen vascular diseases and rheumatoid diseases that may require management systemically. The third red eye differential that must be familiar to a general practitioner is subconjunctival hemorrhage. Patients with subconjunctival hemorrhage typically wake up to a red eye that is uniform and that is localized to a certain sector of the eye. This may be alarming for some patients, which may even cause them to go to your emergency room. But if the patient is properly evaluated and is deemed to have no signs of decreased vision or no other history of high impact trauma, the patient may be safely managed and may be safely reassured that the subconjunctival hemorrhage will disappear in around 2 weeks with conservative management. A common complaint of red eye is seen in patients who have a history of sunlight exposure, such as farmers or drivers, who complain of a triangular fold of vascular conjunctiva creeping into the cornea, called a pterygium. Normally, pterygiums may be managed conservatively with lubricant eye drops. However, if the lesion encroaches upon the visual axis or the center of the cornea, it may be removed via excision. Other causes of red eye include those caused by blood trauma. Hyphema is the collection of blood in the anterior chamber, as seen on the left picture, while hypopyon is an infectious or inflammatory process of which pus accumulates in the anterior chamber. Irritant causes of red eye include the presence of a corneal foreign body in patients who did not wear eye protection during work and are hit by a foreign body on the cornea. This will present with severe eye pain and foreign body sensation and may present with decreased vision. In cases such as these, it is important not to manipulate the eye further and refer the patient to ophthalmology for removal of the corneal foreign body. However, if the patient complains of a foreign body sensation in the eye, but you are unable to locate a foreign body on the patient's cornea, you may consider that the foreign body may be located in the patient's tarsal area. Hence, flipping of the eyelid is important to do, and if you see a foreign body such as this, you may remove it safely using a cotton applicator stick. Another chief complaint that is common in our clinics includes the presence of pruritus or itchiness of the eye, the most common cause of which is due to blepharitis, a condition in which the eyelid margin is chronically inflamed due to toxins secreted by Staphylococcus. This would present with inflamed eyelids, swollen eyelids, oily discharge from the eye, clumping of the eyelashes, with formation of collarettes. Another cause of blepharitis may be due to seborrheic causes or dandruff. In here, we see dry, flaky lashes with inflamed eyelid margins. If uncontrolled, blepharitis may progress to the formation of hordeolum, or in the colloquial term, colitis. These are focal staphylococcal infections that present with red and painful tender masses, which may be due to acute swelling of the glands of Zeiss and Moll and by the meibomian glands. In time, if the inflammation resolves, a hordeolum may become a chalazion. A chalazion is a focal chronic granulomatous infection of the meibomian gland. This is distinguished from a hordeolum in that it is non-tender. It may be conservatively managed, however, if the patient has any cosmetic concerns, it may be excised using incision and curettage. However, if a patient presents chronically with hordeolum defined as more than 3 in a year, the concern for a cancerous growth such as sebaceous cell carcinoma must be considered. It is important to assess for the presence of any life-threatening adnexal eye diseases. In this patient, you may see a hyperpigmented lesion on the patient's conjunctiva and eyelids, which may denote the presence of a melanoma. Another cause of patient consult in our clinics is due to adnexal diseases. Patients with dacryocystitis have blocked nasolacrimal ducts and present with epiphora or tearing. The blocked tears in the nasolacrimal duct act as a medium of bacterial growth, hence become infected and subsequently inflamed. The patient thus presents with pain, edema, erythema over the lacrimal sac as shown in the picture, and if you press on that mass, you will note tenderness as well as purulent discharge from the punctum of the patient's eye. Nasolacrimal duct obstruction may be acquired or congenital. As shown in this picture, a patient is seen with a congenital nasolacrimal duct obstruction. If not treated properly, nasolacrimal duct obstruction may progress to lacrimal sac abscess. Patients may also consult the OPD due to the presence of protrusion of the eyeball. Protrusion of the eyeball is usually due to thyroid eye diseases in adults, as shown on the picture on the upper right. However, it is also important to assess for the presence of masses, as these can be also life-threatening. This slide shows life-threatening orbital masses that require urgent management. Lastly, patients come to the OPD due to the presence of strabismus or the misalignment of the eyes. This may or may not produce diplopia. Patients with strabismus may have esophoria or esotropia, which means that the eye is directed inwards, exophoria or exotropia, in which the eye is directed outwards. Vertical strabismus include hyper and hypotropias. Two patterns of strabismus are important for the general practitioner to know. The first being third cranial nerve paresis. As you may recall, the third cranial nerve subserves the levator palpebrae as well as all the recti muscles, except for the superior oblique, which is subserved by the trochlear or cranial nerve 4, and the lateral rectus, which is subserved by the abducens or 6th cranial nerve. A patient with third cranial nerve paresis presents with ptosis of the involved eyelid and a down and out eye that is unable to adduct or elevate. Patients with third cranial nerve palsy need to be assessed for the presence of any pupillary abnormality, namely a pupillary blowout, as it may be a sign of an intracranial aneurysm. The second pattern of strabismus that the general practitioner should know is the presence of 6th cranial nerve paresis, in which the patient is unable to abduct the involved eye. The picture shown on the upper right shows a left eye that is unable to move to the left. Hence, an eye with 6th cranial nerve paresis may present with an inwardly deviated eye. This is usually caused by diseases that cause an increased intracranial pressure. The next part of the lecture is on the common ER cases seen. Before assessing a patient in the ER, we must always take the visual acuity first before examining the eye. As you may recall, visual acuity is the ophthalmologist's vital sign. Ophthalmology only has two true emergencies, namely chemical eye injury and central retinal artery occlusion. The first true ophtha emergency is chemical burn. If a patient presents to you with chemical burn, immediately do your intervention, as it can lead to blindness. Proper history is important, as it is important to differentiate between the medium of injury. Alkali injuries are commonly found in patients who use drain cleaners, fertilizers, or construction workers who work with cement. Alkali injuries are more serious than acid burns due to the mechanism of saponification or liquefactive necrosis. Due to liquefaction, the eye is unable to resist the entry of the alkali, hence deeper penetration of the offending agent. Acid injuries are found in patients who work with car batteries, patients who work with muriatic acid, or patients who work on aircon or refrigerants. Acid chemical burns are more benign than alkali burns due to the presence of the mechanism of coagulative necrosis, in which proteins coagulate, hence forming a thick barrier that does not allow deeper penetration of the acid. Despite it being less serious than alkali burns, both still have to be treated aggressively. The first principle when a patient comes to you with a chemical burn is to irrigate the eye. Do not take the patient's visual acuity and do not take any history. As long as you are sure that the patient was exposed to an acid or an alkali, immediately irrigate the eye with clean water, or if it is unavailable, you may use carbonated beverages if water is scarce or unavailable in your location. In the emergency room, copious irrigation is done, as well as the application of different medications. For the general practitioner, it is important to start the patient on topical antibiotics such as levofloxacin or moxifloxacin every 4 hours in order to reduce the chance for infection. Prompt referral to an ophthalmologist is required as chemical burns may be vision-threatening. The second true emergency in ophthalmology presents with sudden, painless, profound loss of vision. This is called the central retinal arterial occlusion, in which the central retinal artery is occluded. Patients present with the presence of a relative afferent pupillary defect on the affected eye, as well as a pale retina with a pathognomonic cherry red spot. Patients with central retinal artery occlusion require urgent management. Temporizing measures include ocular massage, which may displace the thrombus or embolus to a more distal site. Measures to produce vasodilation include rebreathing through a bound paper bag or use of sublingual isosorbide dinitrate. Lowering the eye pressure using medications or through anterior chamber paracentesis may be done. However, a golden period of 90 minutes exists before irreversible retinal damage is done. Hence, prompt referral to an ophthalmologist is important. Common ER cases include the presence of corneal foreign bodies and abrasion. These usually occur in patients who work without eye protection and are hit in the eye with various foreign substances. These usually present with severe eye pain, tearing, eye redness, foreign body sensation, photophobia, and variable lid swelling. Metal corneal foreign bodies, as shown, need to be removed under slit lamp guidance. However, conjunctival foreign bodies may be safely removed using a cotton applicator stick. Management of corneal foreign body and abrasion requires removal of the foreign body, as well as use of antibiotics in order to prevent infection. It is important not to start the patient on any steroids, as this may cause immunosuppression of the cornea and cause the production of other stronger infections such as fungal or pseudomonal infection, which can cause microbial keratitis. Perforating injuries of the eye are also seen at our emergency room. These injuries may be work or play related, may be due to assault or accidents. Perforating injuries may be due to sharp objects, projectiles, or through blast injury. An example of globe perforating injury is the Indian pana. If you see a patient like this, do not attempt to pull out the foreign body as it can cause prolapse of the intraocular tissue. What you should do is to stabilize the patient's eye and to prevent the patient from pulling out the object. Corneal perforating injuries can distort the eye by leaking the intraocular contents. Perforating injuries may also penetrate the sclera. Management of perforating injury requires determination of the nature of trauma and extent of injury. Therefore, always manage the patient's ABCs first before managing the patient's eye. Provide anti-tetanus prophylaxis to the patient and start the patient on broad-spectrum topical and systemic antibiotics. Apply an eye shield in order to prevent further harm and avoid manipulation or pressure on the patient's eye. Prompt referral to an ophthalmologist is required for eye repair. Contusion injuries of the eye may be due to open or closed globe and may present with subconjunctival hemorrhage as discussed or contusion hematomas. It is important to assess for the nature of the injury, if it was high velocity or low velocity, and the presence of associated symptoms that may reveal retinal detachment, such as for the presence of floaters, for the presence of metamorphopsia, or the presence of flashes of light or photopsias. This was previously discussed a while ago. Subconjunctival hemorrhages may be safely managed and observed as long as the patient does not have a history of decreased vision as well as a history of high impact globe injury. Management of subconjunctival hemorrhages or contusion hematomas may be conservative. However, we must always advise the patient to watch out for any visual changes that may happen during the healing process. Blunt globe injury may cause hyphema or the collection of blood in the anterior chamber of the eye. ER management is usually conservative and may resolve after a few weeks. Prompt referral to an ophthalmologist is still important in order to manage traumatic hyphema. The following pictures show ruptured eyeballs, which are not apparent due to the absence of visible perforation. However, you will note deepening of the chamber of the eye as well as the presence of severe chemosis, which may be due to prolapsed intraocular tissue. An example of a ruptured eyeball is shown. The management of blunt globe injury is the same as perforating globe injury, in which you must always prioritize the patient's ABCs first. You have to apply an eye shield. You have to start topical and systemic antibiotics, prevent further damage to the eye, and prompt referral to an ophthalmologist. Urgent red eye conditions may also be seen in the ER. The first, as was previously discussed, is acute angle closure glaucoma, in which a patient will present with severe eye pain and blurring of vision. Always remember that conjunctivitis and subconjunctival hemorrhage does not present with decreased vision. Hence, if a patient presents to you with severe eye pain that is hard to touch as well as with decreased vision, the patient should have a consideration of acute angle closure glaucoma in mind. Acute angle closure glaucoma is managed through the use of medications that decrease the intraocular pressure. Another cause of red eye, especially in infants, is due to gonorrheal conjunctivitis that presents as a hyperpurulent, creamy white discharge from the patient's eyes. If you wipe off that discharge, in about 30 seconds, the same amount of discharge will appear. This is a potentially blinding condition that requires urgent management through early irrigation with sterile solution and the use of antibiotics. Treatment of gonorrheal conjunctivitis is accompanied with treatment for chlamydia using azithromycin. Another red eye differential that must be treated urgently is retinoblastoma. Patients are usually young children, age of 2 or below, who present with a cat's eye reflex or leukocoria. This can also present with the patient having eye misalignment or a patient having fall injuries on one side in particular. Urgent surgery is required for such as this is a life-threatening condition.